Bismillahirrahmanirrahim. Thank you everyone for attending this session, one of the neuromuscular series which we started from last year. Today's session is a very interesting session and one of the neglected topic which we need to readdress and emphasize on, which is spinal muscular atrophy. And this is one of the talk which we're going to address today. And today's talk will be held by Dr. Fatmah Zahmi, who is our neurologist, female UAE neurologist, who is having a dual fellowship in stroke and neuromuscular. She had her neurology residency in States and had fellowship in neuromuscular disease in States as well. Her main interests are in inflammatory myopathies. She performs her own nerve conduction and EMG by herself as well. We share together many other topics. Dr. Fatmah will be talking today about spinal muscular atrophy. Dr. Fatmah, the microphone is yours.
So I understand that the audience is a broad range of physicians from expert neurologists to general neurologists to, I'm not sure if we also have internal medicine physicians or primary care physicians. Have you guys, can't wait to see your next SMA patient. No disclosures, except that I do have some slides that were donated to me from, we're gonna learn a little bit about the epidemiology of SMA, the clinical features, and what are the current therapies available, with the goal of you falling in love with SMA. But it's not that common, so you might not find your love very soon. So what does spinal muscular atrophy? So genetic disorders, or a group of genetic disorders that would lead to gradually progressive muscle weakness and atrophy. So it's loss of the lower motor neurons, anterior horn cells of the spinal cord and the brainstem. So if you, as an adult neurologist or dealing with adults, you know ALS, you can think of this as the hereditary form of motor neuron disease. It is an autosomal recessive, and that's why it's the incidence is between, some books would quote 1 in 10,000, while others basically saying it's between 4 to 10 per 10,000 live births. Now, I think the variation, because our diagnostic tools and I don't want to say the suspicion, but now we think about it more because there's treatment that we can offer. So autosomal recessive, so you need to have 2 abnormal genes. So what is the carrier frequency? So the carrier frequency varies according to the region, ethnic background, or statistics, basically. So almost 1 in 50 to 1 in 90. So 1 out of 50 people will have 1 abnormal gene that could lead to SMA. In the United States, where we think they might have better statistics, the carrier frequency between different ethnic groups is 154, based on a detection rate of 91%. That means if your test is really good. And that's why if you were in the United States, among all these different ethnic groups, your chance of being a carrier is 1 in 500. There was this, I found this table, which was interesting. It's in my go-to is genereviews.com. It's with PubMed, and it's really good for any genetic disorder. And they put this table as a reference for the carrier frequency. So they somehow they found that the carrier frequency among Arab populations almost 1 in 60. However, there is no reports about the actual incidence. Among whites, the carrier frequency is 1 in 45, and the incidence is 1 in almost 8,000. And in Jews, 1 in 54, 1 in 10,000. You could say it's the least carrier frequency among the Black population, with the least incidence, 1 in 18,000. So yeah, so we say, oh, it's a hereditary disorder, then where's the family history? Well, most of the time, the family history is going to be negative. So as we said, the carrier frequency is 1 in 50 almost, which means 1 in 10,000. You need, if the two or the two people with the abnormal genes, they would have 25% of having abnormal or affected child. But a lot of times you would have one affected parent, and then you get a new mutation, which would lead to the affected child rather than both parents being carriers. So then we go into more about the genetics of SMA, so spinal muscular atrophy. So the classic form that mostly talked about, and that where all the clinical trials and the gene therapy is working on, is the 5q type. So what does that mean? It means they address the gene mutation that's present on chromosome 5q. So this represents 95 or a little more than 95% of all SMA. And what happens, so this 5q has a gene location for SMN1 and SMN2. So these SMN1 and SMN2 are responsible for producing a protein called survival motor neuron protein, right? And if you have to have this disease, you have to have either deletion on both SMN1 or point mutation, but biallelic mutation. So that's the autosomal recessive. So either you can even, we've seen compound mutation. So one chromosome will have point mutation and the other would have a different form mutation. So you can have compound pathogenic mutations. So biallelic mutation or deletion on this chromosome 5. So these two, the SMN1 and the SMN2, are important in producing the protein called survival motor neuron protein. So obviously it's important for the survival of the motor neurons. How does it do that? Well, we think it has something with preventing apoptosis, but there's ongoing research. We're not really sure how does it do that. Also has a role in establishing the intracellular matrix complex needed for proper RNA splicing. But for the motor neurons to survive, they need SMN protein, which is produced by SMN1 and SMN2. So what's the difference? Okay, so this is just to highlight that most of the SMAs that we talked about are 5q, the classic forms. There are other forms of SMA that are non-5q. They're extremely rare, and they have different genetic mutations. We're not going to talk about that today. So SMN1 is where the problem is. So if I have SMN1 deletion or biallelic mutation or deletion, that's when I develop SMA disease. So the disease is SMA, the gene is SMN. Now, but what about SMN2? Why do we talk about it? Well, you can think about survival motor neuron 2 gene, and you can think about it as a backup gene. So, or kind of a lousy SMN1, or I don't want to say mutated, but you can say a lousy SMN1 gene. So it is not as efficient in producing the SMN protein as SMN1. So there is a an exchange. I think this slide shows it. So the SM11 in the exon 7 has a C, while the SMN2 has a T, and I'm not into genes or all kind of this molecular medicine. However, when you have the T, then the efficiency of the protein or whatever protein is being produced is not stable and doesn't get transcribed into a proper SMN protein. And that's why, so it gets degraded. So most of the SMN protein that comes from this gene that only it gets degraded at only 10% gets transcribed. So the proper SMN protein in your motor neurons comes from SMN1. Now, SMN2, Allah gave us a different variable number of SMN2. Not everybody has the same number of SMN2. So some people would have 1 copy, 2 copies, 3 copies. And we'll talk later how that affects the phenotype expression of the SMN disease. SMA. Okay, so this is a normal person. So we have both SMN1 and SMN2, and most of my protein comes from SMN1, and very little comes from SMN2 because SMN2 is a lousy SMN1. So this is if the person has a mutation or a deletion of biallelic deletion of the SMN1, then I get nothing from the SMN1 protein, then I don't have any survivor motor neuron. So then I'm depending on how good my SMN2 is, right? And we said that T on the exon 7 makes it lousy and only make 10%. So I'll make a little bit. So the point here is that, as I mentioned, we have, every person can have a different number of SMN2, 1, 2, 3, 4. The more copies of SMN2 that I have, the better motor function. And that's why the phenotype will not be as severe. So the worst ones are the ones that would have the lowest copies of SMN1. Sorry, SMN2. So the severity of the SMA phenotype, the clinical phenotype, reflects or affected by the number of SMN2 gene. The more SMN2 that I have, the more SMN protein that I will make, and I will have less motor symptoms. I hope that's clear. Okay, this another slide maybe clarifies that idea a little more. So we'll talk about different types. So the types of SMA, spinal muscular atrophy. SMA is the disease, SMN is the protein, and SMN1 and 2 are the genes. So the phenotype spectrum or the clinical classification basically is not based on the genetics, but it was decided way before we know the genetics of SMA, and it's based on the maximum motor function. So if a person was able to walk, then they call them SMN3, so type 3 SMA. Okay, so type 1 is the type, or type 1 we mean this is a patient with SMA that he was never able to sit or walk. So usually the onset would be before 6 months of age. And they would have a lower number of SMN2, only 2. SMA type 2, these are called the sitters. So they are able, at some point, they're able to sit unsupported. And usually the onset is, well, later than 6 months, but less than 18 months. And they would have, we expect them to have a higher number of SMN2 genes. And then we have type 3, which is the walkers. So type 3 is a child that is affected by SMA, but at some point he was able to walk. Usually the onset is beyond 18 months, so a year and a half, a little later than a year and a half. However, this does not mean that this SMA 3 type will continue to walk forever. No, you establish or the name or the label SMA 3 or 2 is that the best motor function that they have achieved at some point in their life. A lot of these kids, if left untreated, will lose their ability to walk or sit as they get weaker. But because they were able to walk at some point in their life, then they are labeled as SMA 3. And why is that important? Well, because now that when we go to clinical trials and approval by insurance, they need to have that separation between the different types. And then we have SMA 4, which is extremely rare, and its age of onset more than 21 years, and these guys are very mildly symptomatic. So adult onset SMA. So just to show you the percentages, so most patients with SMA really start before they're 6 months of age. So they fall as type 1, and that's 55 to 60. So almost 2/3 of SMA patients are type 1. 1/3 is type 2, which means at some point they were able to sit unsupported, and 15% would be type 3. Again, the adult onset is rare, and there's also type 0, which is prenatal, right? So there's also type 0, which is prenatal. So these kids, we'll talk about it, I think, later, but they were already born extremely weak. They might have contractures, and their lifespan is less than 6 months. So that's extreme. So again, just showing the different phenotypes again. So the SMA was historically classified before we know anything about their genetics based on the maximum motor function that they achieved. So SMA1, they were never able to sit. They can develop head control and they can roll over, but they are never able to sit. Type 2 SMA are the sitters, and usually between 6 months and 18 months, they sit, but they don't walk. And then you have the walkers, and then you have the adult onset. So as we said, 2/3 of the SMA patients belong to SMA1, meaning that the onset starts before 6 months of age, and they are not able to sit or walk. And so initially we had natural history studies. So what happens to these people? So with as they get older, this is what happens. They will either die or become dependent on the ventilator, whether it's invasive or non-invasive. Some parents would choose not to do the invasive ventilator. And as we said earlier, that if I have a higher number, if I have more of the SMN2 gene copies, then you're shifted to the right. So you're not needing ventilator as soon as the ones who don't have as many SMN2 copies. So the natural history studies were, in the 90s and early 2000s, The median age of death or needing invasive ventilator for most of the day was 7.5 months. A little bit later, between 1995 and 2006, that has extended from 7.5 months to 24 months. So these kids lived for 2 years. What has changed? There was no genetic therapy or modification, gene modifying or whatever therapy. The only thing that has changed is the implementation of multidisciplinary care. The fact that we were able to provide nutritional support and ventilatory support, avoid or treat complications. So this is by itself probably better than any of the drugs we have, right? Prolonged from 7.5 months to 24 months. I'm not going to comment on that. So this is a little, I don't like when I see all these colors, but basically it shows us that people will decline with time. So if my, this is a different scales of motor function, and I would achieve something, but with time, if left untreated, they're going to lose their ability to walk, or you know, the 6-minute walks or grasp, or all these scales they use for motor function, head control, sitting. Okay, so briefly, we said the type 1 prenatal onset. This is a very poor prognosis. There's nothing you can do. There's no postnatal screening. So really, just recognize this, I mean, maybe for the parents and genetic counseling, but they are born with severe weakness. They would not last more than 6 months, very soon. The type 1, so they're not able to sit without support. So if you put the child in some kind of chair and, you know, something behind him that's not sitting, they have to be able to sit without support. So the type 1 are the non-sitters. They could, however, develop some head support, head control, and some rolling. Usually would, you know, have the weak cry, difficulty with feeding, poor weight control, eventually will develop respiratory weakness and needing a non-invasive ventilator. Usually, or at least historically, they would die before the age of 2 years. But I think these stats are going to change because now we have, whether it's supportive care or the new disease-modifying treatment, if you want to say. Type 2 are the sitters. So if you see, he is able to sit without support. This one is not, but they would never walk. Now, they would develop significant kyphoscoliosis and joint contractures. Again, historically, they would die, or lifespan is up to 25 to 30 years. But again, things are changing. And yes, they were able to sit at some point in their life, but let's say we're treating adult patients and I see the patient and now he's not able to sit. We have to have a good history, whether it's from family or from documentation and the medical records, so that we can label the patient with the right label. Is this type 2 SMA or type 1? If he was able to sit at any point of time, then it is type 2. Very important. And then the type 3, which is after 18 months to 18 years, or now we say 21 years, and these are milder. They are able to walk, They might look like Duchenne or Becker's muscular dystrophy. So if you remember, Duchenne probably starts at 3 to 5 years of age. So they will have proximal muscle weakness, and that's why they have a waddling gait, just like any other, Duchenne or other muscular dystrophies, sure. They would have the Gower signs. They will, again, eventually they will lose their ability to walk. But remember, if they walked once, they are still SMA3. They have this very prominent tremor, or people call it polymini myoclonus. Very interesting to see. And these kids are extremely smart. They're very, very intelligent. I've met kids and adults with SMA, and they're usually maybe above average IQ and very highly achieving, actually. And they can have a normal life expectancy. Again, with the as we provide supportive care. They may or may not develop respiratory. Might develop a degree of respiratory weakness and might need a nighttime BiPAP. And then the mildest form, which is type 4, that's less than 1%, and the symptoms will develop after the age of 21. They might look like limb girdle muscular dystrophy. So if you're working somebody up for limb girdle, but something didn't make sense, whether it's the EMG or gene panel, then think about adult onset SMA. Again, just a summary, really. I don't think I have anything more. Just some people would like to differentiate in type 3 SMA, whether it's SMA type 3A or 3B. So 3A is started after 18 months of life, but less than 3 years. And then type 3B is after 3 years of age until 21 years. It doesn't really matter. So when do you suspect, or what kind of investigations would you, what kind of positive or significant labs that you might find? Well, CK could be normal, or it can be the highest, not more than 10 times the upper limit of normal. But that's rare. It might be slightly elevated early in the disease. If you do a nerve conduction study, so early on you will have normal CMAPs, but at least as with time, their muscle bulk, their muscles are gonna be smaller, so their CMAP might look smaller in somebody who had the disease for a long time. On the EMG, you will see active denervation with fibrillation potential, positive sharp waves. You see reduced recruitment, so really neurogenic pattern. But again, with the longer disease, let's say disuse atrophy, or somebody who's been bedridden for a long time, you might see secondary myopathic changes. So that can lead to confusion sometimes. Muscle biopsies, well, I hope we don't do a muscle biopsy in somebody who ends up with SMA, because genetic testing is really easy, feasible, and probably get the results sooner than muscle biopsy. But if you do, or historically, you would see chronic denervation, type grouping, and fascicular atrophy. So as we lose a certain motor neuron, the muscles that receives that motor neuron, anyway, it's not important. So let's say you've seen somebody who's weak, and you suspected, probably if you are dealing with pediatrics more than adults, but yes, don't forget SMA, even if you're dealing with adult patients. So then ask for genetic testing. Genetic testing is very is highly sensitive and specific, and we do next generation sequences and quantitative analysis of the so you want to see if there is SMN1, is there is biallelic deletion or pathogenic mutation. And once I establish that diagnosis, so this patient two abnormal SMN1 or two deleted homogeneous deletion, then I also like to have a quantitative analysis of the SMN2 so that I can see how many copies, which can predict severity of the disease. So how do you do that? Who are you gonna call to get the genetic testing? I'll leave the number at the end, but Biogen is nice enough. Biologics provide free genetic testing. If you're suspecting a patient, whether it's an adult or a child, you can do a dried blood test, just like the one we do for Pompe. So if you call this nice guy, Yahya, I've used it once, and I think I received the results within, it was pretty fast, I think 3 to 4 weeks. So see a patient, this is a treatable disease. So I think, always think about it. I always think of the things that have treatment. So whether it's Pompe or the SMA, so the test is pretty easy. These guys, biologics provided free of charge. So just call their representative, get the card, just like doing a finger stick for glucose, and send it, and you're all good. So why do we care about SMA? Well, or in adults, it's usually, as I said, most of the cases, 2/3 are going to present as SMA1, which is before 6 months of life. And I think I said another 30% as type 2, which is before 2 years of age. And then type 3 after age 18 months, which is 15%. And then the very, very rare adult onset after 21 years of age. Well, even as an adult neurologist, I think it's important for us, and if you're a general practitioner or internal medicine, these patients are going to live longer now with the better supportive care, multidisciplinary care. So it is important to know about these diseases. Also, there are patients who were diagnosed, who knows, 20 years ago, based on the phenotype as Duchenne or something that's more common, and now they are living longer. But if you find that somebody carries this diagnosis just based on how they looked without proper genetic testing, maybe it's good to rethink the diagnosis and ask for a genetic testing. This is a progressive disease. And the patients do, so when they looked into, is there a value in treating an adult? Well, I'm already on a wheelchair and I'm not walking. Well, if they're still able to swallow, they are not needing a PEG tube, people think that it is worth maintaining the motor function. If I am not on invasive ventilator, maybe I am on overnight BiPAP. As I get weaker, as the patient gets weaker, he might need to be on invasive ventilation. So maintaining him or preventing that further deterioration in the respiratory muscle function is worth it. Some of them would not be able to carry a laptop or a phone, but they can use their fingers to type or like use a trackpad. And if they maintain that ability to the patient, to the caregiver, it's very important because it's really their way of communication. So before all this excitement about the disease-modifying, I'm going to call it disease-modifying therapies, there's also a statement that was kind of late, but it was made in 2018 about having a standards of care, basically depending on a multidisciplinary approach where you can give it. So they will give you the guidelines to address each and every aspect of the care, from the pulmonary care, the nutrition, the orthopedic, pain management, if they get admitted with an infection, for example. So basically, this statement is to mainly supportive care, prevent and manage complications. So in regards to respiratory function, in places where there's a where we have a neuromuscular center or MDA, muscular dystrophy association, they run these multidisciplinary clinics where patients would come periodically and have pulmonary evaluation with forced vital capacity, usually sitting and supine, because with when you lay down and the diaphragm pushes up on your chest, you actually can lose a significant amount of your FVC. If there is anything to suspect that these kids become hypoxic at night, overnight sleep study is warranted. Sometimes non-invasive ventilation is needed. They should have regular swallowing assessment and watch for them developing kyphosis and scoliosis, because that can also affect their ventilatory function. So this is interesting. Until actually my training and fellowship, I haven't really, I never appreciated how much that scoliosis can affect their respiratory function and the quality of life. So it's very important, and they always have orthopedic on board. So if the patient, a younger patient, so before they reach skeletal maturity, they have the option of this vertical expandable, whatever prosthetic, or growing rods. But if it's closer to somebody after puberty, they reached a skeletal maturity, then it's a regular spinal fusion. They might develop contractures, elbows or heels, ankle, I mean, and that might cause or impair physiotherapy. So surgical release of contractures is also important. And always don't forget to ask about the nutrition. I don't know why is this not done, but I mean, my clinic, at least every patient needs to have their weight at least every visit, unless they visit you every day, but every 3 to 6 months, it will be important to see. Have, family education and dietitian input is important. Also bone health, because with the immobility, you have to check for bone density and put them on proper medications if needed. Treat constipation like any other chronic patient. So that's the supportive multidisciplinary care. And again, I'm not expecting all the audience in this webinar to offer that, but at least if you run into one of these patients, and make sure that they are being seen by the proper services, that they are put in contact with somebody who can provide or refer them to get the proper services, because they can be in a lot of pain, and really all they need is just to have a physiotherapy where they can do regular stretches and have some kind of prosthesis to prevent the contraction. It does make a lot of difference. So it's just to keep your eyes and mind open, and whether it's SMA or any other chronic condition, make sure they are able to reach the right providers and the right services. So do we have something called disease modifying therapy? So we know we are supporting them, we are preventing and complications, and treat them promptly if complication happens. But do we have treatment to prevent this from getting worse, prevent the motor neuron loss? Well, over the last few years, it's been a very exciting time for neuromuscular neurologists and the parents of these kids, obviously. So there are a lot that are being in clinical trials right now, but we have 3 FDA approved medications. 2 of them are available in UAE. So the gene therapy, so we have a gene replacement therapy. So I have an abnormal or absent deletion of the SMN1 gene. So the gene therapy, meaning you have a viral vector that will carry the gene and put it where it's missing. And this therapy is approved in UAE for children. Is it below 2 years or 2 months of age? I think it's below 2 years of age. And that's a one-time injection so far. Now, for patients that we are more likely to see, gene therapy is not available yet, but what we have is splicing modification therapy, and Nusinersen or Spinraza, which is made by Alexion Biologics, is not Alexion, Biologics is one of them. So the 2 medications that are currently offered for adults are SMN2 splicing modifier. So let me see if I have a slide. So do you remember that we have the SMN1 and the SMN2? So the SMN1, if I have abnormal SMN1, then I have the disease, and I have this backup SMN2 gene, which is a little lousy. So people thought, well, what can we do? Well, we can make SMN1 gene and introduce it to the patient genome, or we can make this lousy SMN2 gene work better. So the first one that was approved was in 2016, and that was this Nusinersen. And it's a splicing modifier. So it's a small molecule, and it goes where the SMN2 gene, and somehow works on, we said something related to the exon 7. Now the survivor motor protein that is produced is going to be more stable. It's not going to be degraded right away, and that will allow the motor neurons to survive longer. So that's one way approach. The second was the gene therapy. I think I have, yeah. So the splicing modifiers, also called antisense oligonucleotide therapy. And this is the first FDA approved for SMA. It was approved in December 2016. And again, the the protein or the product, the oligonucleotide, antisense oligonucleotide, is delivered intrathecally, and it will target or reach the motor anterior horn cells and work on the SMN2 gene. So now the protein that is transcribed is going to be more stable. And this has been very well studied and published, that it does improve patient motor function and event-free survival. So the main kind of landmark trials is the ENDEAR trial for the infantile onset or the SMN1 patients, and they found that the risk of death or needing ventilation was cut by almost 50%. This is very, very significant compared to the no treatment or placebo group. Now remember, this is intrathecal injection, so really the sham group is, anyway, so, and the motor function, and then we have the CHERISH group or the CHERISH trial. So the CHERISH trial was meant for SMN2 and 3, so age of onset beyond 18 months and less than 21 years. And again, almost 50 to 60% improvement in their motor function or motor scales. And they use different scales that are very extensive, actually. Side effects were not more than the sham group or what is expected in the natural disease progression. This is the Hind 2 motor scale. It's just too much. And this is the some modified HFMSE score. I'm not treating any of these. I hope I do get to treat some adults, but I hope they come up with scales that are easier to implement, because this would need a specially trained nurse or physiotherapist. So the people have been working on the concept of these antisense oligonucleotides, and studies have been started maybe in the 2009 and up until 2016, where the FDA approval finally came, and it was a big landmark in the SMA and all the hereditary disorders history. As of now, we have more than, worldwide, there are more than 10,000 patients with SMA that are currently being treated with Nusinersen. Most of them, the black is actually part of clinical practice. This is a standard of care. Only 1/3 of them are adults, and when we say adults, I don't mean that 1% that has adult onset SMA. No, it's the adults that survived, whether it's SMA 2 or 3, most likely 2 or 3, less likely to be SMA 1, but they have reached the adult stage, and there is some motor function to preserve. As I said, even if it's just sliding my finger on a trackpad or maintaining the ability to swallow naturally or avoid invasive ventilation, it is still worth treating. And this is now a standard of care. If you have a patient or if you suspect these people deserve have a proper evaluation and to be offered treatment. So most of the patients are in actual proper clinical practice. Some of them are still in clinical trials or expanded access program, clinical development program. So how is it administered? And I remember I was still in training when the Nusinersen got approved. I was doing my fellowship in Chicago, and everybody was very anxious about the intrathecal injection. So it has to be delivered intrathecally. And well, a lot of these are kids, and how are we going to do this LP regularly? So initially you'll have to do it every 2 weeks for 3 doses, and then 1 month, and then at every 4 months. And some of them have already had scoliosis and corrective surgery, and everybody was extremely nervous of the tolerability and the feasibility of giving the medication. But I think we started to do with kids. They used to have it done in the OR. I think now it's much people. I mean, we're physicians maybe not as afraid. Another thing we were nervous about, the providers, pediatric neurologists were nervous about, well, what happens if, you know, we have the drug, we have the needle, and we could not get the LP, you know, that happens. We could not get into the CSF space. This is a very expensive medication. Are we gonna waste that 120,000 vial? But it seems that it's now feasible and well tolerated by patients. So the first dose, the first 3 doses are every 2 weeks, and then dose number 4 is going to be at 4 weeks, and then it's every 4 months. Every time we do it, send some CSF for evaluation. Common side effects that are seen with antisense oligonucleotide, thrombocytopenia, coagulation disorders, injection reaction, etc. So in summary, it's the first FDA approved for SMA disease. It is also approved and being used in UAE for all age groups. The cost is $125,000 US per vial per dose. And currently, as we said, more than 10,000 are treated. So back to the slide. So I want to also talk about, I know adult patients are not eligible to get the gene transfer therapy, but I think it's important to know a little bit about it. So they use this virus vector, AVV. I think it's a form of adenovirus. So they modify it. It carries the SMN gene, and it's injected intravenously, not intrathecally, and it would target, it will only go to the motor neurons, rapid onset, and it has a clinical benefit only by one. I think the first trial that was published on this and that granted the FDA approval was only on 15 patients with SMA1. So they injected, so it's only one injection. It's extremely expensive. I think I'm going to mention that later, but only one injection. So it does improve motor function. So if you notice, all of these patients are early onset and the CHOP, whatever, this is a motor score. And with age, they continue to improve their motor score. And these are, yeah, the first 15 patients on that trial. So the actual names, I don't know how they chose this name, but Zolgensma, or used to be AVXS, approved, FDA approved, also approved in UAE for age less than 2 years. The cost of one intravenous injection is $2 million US. I believe there was two, I heard Jalila, I'm sure Jalila gave one patient, and I think one of the private hospitals in Dubai also gave it. So it is available. And yes, the sooner you preserve or prevent these motor neurons from from dying, then the better the motor function over the long term. Okay, so we mentioned the first SMN2 splicer. So the gene replacement works on giving us SMN1, and then the other method is to make SMN2 more productive by modifying the splicing. So there is another one in the market now. It's called risdiplam or Everesti, whatever, risdiplam. So why is it exciting? Because it's an oral antisense oligonucleotide. It is approved, it's FDA approved. It is not in UAE yet. The same, so the FDA approved it for kids age, for kids that are 2 months and older. Again, improves the survival of the motor neurons. And I think it was an open label study of 21 patients, and it did improve survival. It decreased the need or improved the time without the need of ventilation, and also motor function. And so we really have just the abstracts of these trials. The final results are not published, but it is also tried in SMA2 and 3, and they tell us that it did have meaningful motor improvement. So again, it's antisense oligonucleotide, so prevent or modify the splicing, so the protein is more stable. Seems that it's well tolerated and safe. This is the clinical trial. Was the granted FDA approval was on 21 patients of SMA1. And some other trials for SMA2 and 3 are still going. So it got FDA approval in August 2020, so not too long ago. Age 2 months and older, and it's oral. It's not yet in UAE. So we're dealing with adults. What's going on with adults? We said there's 10,000 around the world that are treated with, well, the drug that has been around the longest is the Spinraza, Nusinersen. Wow. And that's why it's we have the most data, and they have a very good database and helped us understand the long-term effect, and if the benefit continues to be seen in these patients. So there has been some cohorts that were published about adult patients. It seems that 3 cohorts from Germany, 1 from the US, a group of researchers looked in Italy, looked in retrospect about the patients that received the medication, and tried to put together what are the challenges and the benefits that were seen in these patients. So again, it's the main challenge is that these patients can have headache, pain after lumbar puncture, the difficulty of the LP itself, and if the patient, chronic patients, if they have severe scoliosis, we're not able to. And then, since it's not really an easy LP, most of them, probably all of them, need to be performed under X-ray guidance. So there's the radiation exposure. In conclusion, it was safe and feasible for adults, and they felt that it was worth it, that these patients just maintaining what the motor function, and some of them, the SMA3, also seem to actually gain function, not just maintain or prevent them from losing, but also gain. So what's going on in UAE? Well, you know that in UAE we have, well, the Arabs, we said the carrier is 1 in 50 or so, and obviously there's more consanguinity in locally. So we still don't have the clear incidence, and I think we should, as neurologists, come together and try and have some database so we can have proper estimate on the incidence and prevalence in the locally. But from biologics, we know that there are 20 patients with SMA that are currently on treatment with Spinraza intrathecal injections. And that started 2017, so 1 year after approval, not too bad. In the Gulf region, 130 patients are currently being treated. In UAE, so it's obviously a very expensive medications, and the UAE nationals are covered by the government, and I believe there was 1 or 2 patients who were non-UAE nationals, and their insurance did cover for the medication. So that does not, so think about it, it doesn't matter if the patient national or non-national, there are all different ways of getting financial support if the insurance doesn't approve. But I think insurance is getting better. We see this in multiple sclerosis. They used to never pay for any treatment, and now they do. So things are at least slightly better. In the Gulf region, there are 30 adults with SMA that are being treated. In UAE, none of the 20 patients is an adult. They're all coming from pediatrics. And I'm sure there are adults that do have SMA. It's either that we haven't spotted them yet, or they haven't reached the right person. We already said that. This is kind of the life timeline journey of SMA, and again, huge progress. If you've seen or if you've known a parent of a patient with SMA, it's a life-changing, and these guys are very desperate for any form of treatment or clinical trial. A lot is on the line.
Fatmah, how many minutes have we left?
Okay, I'm done. In the UAE, in US, they have implanted the newborn screening. I don't think we have that yet, but I think it should be a good idea, because the sooner you get these guys on treatment, even if they are in the pre-symptomatic stage, the better. So, and yeah, I will keep this slide just because I want you guys to take down the number. If there is a patient, well, I should have done this. So you can refer to one of the neurologists or neuromuscular neurologists in the region. And if you're interested to have the test sent, you can also contact Mr. Yahya from Biologics. I am done, sorry. But basically, keep your eyes open and your mind open. Sorry, I took very long. I hope you guys didn't sleep, but it's not an easy subject.
Thanks, Dr. Fatmah, a lot. It was a very interesting talk. We went to the journey from knowing what the incidence of SMA to the symptomatology and to the treatment. We hope we have treatment for each neuromuscular disease. We had reached up to 650 participants. And to your interesting talk. So we have questions and answer. We exceeded our time, but we're gonna answer a few questions. Most of the questions you answered in your talk, so we're not gonna talk about it. But one of them is there any gene therapy available to cure SMA? You kind of talked about it in your talk, but you can give them a brief answer if you don't mind.
I'm sorry, gene therapy for SMA?
Yeah.
So as you said, there is the gene replacement therapy that is for kids younger than 2 years of age. So it gives them the absent gene or the mutant gene. However, for all ages, there is a gene called gene modifying or splicing modifying. So it's not, we're not replacing the gene, but we are modifying the splicing of the gene. So there are two that can be used in adults. One is available in UAE, and that is Nusinersen, that is delivered by intrathecal injection. Another one is delivered orally, but it's not approved in UAE yet. I'm expecting soon.
The other questions, what's the role of physiotherapy in SMA?
Physiotherapy role is extremely important, and that's the least you can do is to direct your patient to go for physiotherapy. Having even if they just do passive range of movements, even if they just do an orthotics to prevent flexion contraction, it's extremely important, and it will prevent them from pain and complications in regards to the bones and joints, skin. Absolutely important.
Thanks very much. It was a very interesting talk. Thanks for attending this session, Dr. Fatmah. We promise the audience for more sessions in future, and it's going to be coming more and more in the next few months. Thanks, and we hope we share talks same in the next few months. Thank you.
Drive safely, Dr. Abu Bakr.
Thank you.
Take care. Bye.
Thanks. Bye.
Thank you, doctor.